A very warm welcome to you all, our dear participants. So thank you so much for taking the time to listen to this very important topic. So to begin this meeting, we are going to have a word of prayer, and I'll request a volunteer to lead us into a prayer, and then we'll start. Right. Kimberly's Eunice, can you please pray for us?
Let us pray. Our Heavenly Father, we thank you for this time you've allowed us to come and meet and discuss matters pertaining to our health and lives, Lord. I pray that you give guidance, your Holy Spirit, to the presenters, that at the end of this evening and the presentations, Lord Father, we'll have learned a thing or two, Lord. Abide with us even as we go through the rest of the night. We've asked all this, trusting and believing in Jesus' name. Amen.
Amen. Amen. Thank you so much, Eunice. Once again, our dear participants, we want to welcome you to this medical education session. It is without doubt that I know that we have this important topic is of great importance to all of us. You're in the right place, and I believe that you'll not leave the same at the end of this session. So as a way of introduction, good health is a state of being that we all want to achieve. We strive to eat well, we exercise, we get immunized, we take supplements. We do all kinds of activities to stay healthy. We do all these. Sorry. So I'm having a challenge, but just bear with me for a minute. Okay. Can you hear me? Please confirm that you can hear me.
Yes, that's better.
Please, we can hear
you. Can hear me, right?
Yes.
Okay. So, so I was saying that good health is a state of being that we all want to achieve. We strive to eat well, we exercise, we get immunized, we take supplements. We do very many activities to have good health and ultimately live longer. While death is a natural process, you know, unexpected incident, sudden death really shakes us to the core. I will not ask how many people here have experienced sudden death, because definitely you'll not be here. But every one of us knows either a friend or a colleague or a village mate or someone you know who has died suddenly. You have heard stories. She died in her sleep. She collapsed on the pulpit. She collapsed and died while jogging. And she collapsed as she was walking upstairs, and yet she was well. All those stories are very common these days. While sudden death has always been there, it has taken up so much significance, especially after the COVID epidemic. We have so many questions in our minds. We worry about our health. We wonder if it's us who will be next. It is with these concerns that we got this important topic to empower you with knowledge on its cause and how to prevent sudden death and how to stop our kin and our friends, how to support them when they have experienced signs and symptoms that lead to sudden death. Ladies and gentlemen, to help us discuss this important topic this evening, we have a very important guest, Professor Irene Andia. Please join me to welcome Professor Irene. With you can react on your laptops or your phones with a hand clap. Let me see you. Welcome, Irene. Ladies Are you, and gentlemen, are you there? I haven't seen any hand clap. I haven't seen someone raise their hand. Thank you so much. So Professor Irene Andia Biraro is an internal medicine physician specializing in infectious diseases and immunology. She's an associate professor of medicine in the Department of Internal Medicine at Makerere University. She has over 25 years of experience in clinical practice and 22 years of research experience. Her current main research focus is on TB and co-infection and comorbidities. She is happily married, Dr. Samuel Biraro, and together they have two beautiful daughters, Sima and Sanyu. You are very welcome, Irene. So to you, the participants, I request that you really have your maybe pen and paper or somewhere to write. We will listen in and we'll have at the end a discussion, question and answer session. I know that it's a mixed audience, but both their health workers here and they are also the regular people, but I know everyone is going to be benefit from this topic. So at this point in time, without wasting much time, welcome Professor Irene Andia.
Thank you. Dr. Emily.
Yeah.
And good evening, everyone. I'm here to discuss with you a topic. I'm sure that for some of you, the information might not be new, but hopefully that there are new insights and can be informative this evening. Yeah, so greetings from Tira. And I don't know if it's possible to mute people who, if it's possible to mute. It gets a bit confusing to talk. Okay. All right. So as Emily has said, this sudden death, death is death in its own definition is a shocker, but when it occurs to somebody suddenly, it even is a worse shocker. So what is this sudden? What's the suddenity about it? What's this suddenness?
Irene, we can't hear you.
Can you hear me?
Hi, Irene.
Hello?
Yes, I think
can you hear me?
we can hear you very well.
Yes,
Maybe.
hear her very well. Yes.
You can hear
Yes,
me?
we are hearing, yes.
All right, okay. Okay. So as I was saying, what is that? What is this suddenness? So this means this is an emergency. It's an emergency situation. It's occurring out of the ordinary. So somebody is healthy. Is the sadness because somebody has been sick, and then this is the acute episode of that? What is this suddenness? Is it related to the timing? Does death occur in the 1 hour, in the 24 hours, in 36 hours? What is the suddenness? And also occurrency. Where is the death occurring? Is it in hospital or is it at home? Is it in the community? So according to some definitions, one, this is the rapid and unexpected death from natural causes within an hour of onset of symptoms. So within that 1 hour, the death occurs. WHO does define it also in 2 ways. One is a witnessed death, a witnessed event within 1 hour of onset of symptoms. So we can get a fake name of a plant, for example. Muvule is walking, talking with you, gets symptoms within 1 hour, Muvule is dead. The second definition, I'm trying to look for another tree. Ebony. Ebony, you're called that Ebony is dead. Meanwhile, you met Ebony at a party yesterday. So the second definition is related to unwitnessed death, which occurs within 24 hours of having been last seen alive and you are symptom-free. So if you notice the definition is within, if it is witnessed within 1 hour or unwitnessed within 24 hours, you get a report, so-and-so was otherwise well, but they have called in, they have suddenly has died. So each of us has experienced one of these scenarios where you've heard that somebody was in the bathroom, fell, died, or somebody went to work, was not seen, and then within 24 hours has been pronounced dead. So what are all these things that cause us this sudden death? And I put this slide there to show you the different, I even couldn't include everything, but these are the different scenarios that we are going to discuss in detail for some in the next slides. But if you look at the middle we have this gentleman with biceps, but with this whole chest and lungs with a heart. So any sudden disruption of the cardiopulmonary system will result in death. So the issue of sudden is how fast that system is disrupted when you're otherwise in a healthy state. So there are different classifications of causes of sudden death. So we have the medical and critical care emergencies, we have the surgical emergencies, and we have the obstetric emergencies. But for this presentation, because I'm a physician, we shall dwell on the medical ones. So in the WHO report of last year, they showed this whole graph of the top causes of mortality in the world. And these are, oh, sorry. I put this in people with the TB and HIV, but it just depicts generally, even the non-TB and HIV people, that the top causes of death still remain those that are related to the cardiopulmonary system. So ischemic heart disease, stroke, diabetes, road injuries, hypertensive heart disease, and growth. So all these things are related to mortality. So when we think of what are those diseases that are the worst shockers, death causes within 1 hour, the biggest one is a massive pulmonary embolism. I chose this one and I'll go in detail with it later, but top causes, massive blood clot to the heart, number one cause. You can see this gentleman here holding his chest. He's probably from a flight and gets in and drops dead. The second most common cause are cardiac arrests. So cardiac arrests from irregular heartbeats, like we see this. Let me put a pointer. So irregular heartbeats. So ventricular fibrillation. Your heart just is bouncing all over the place. Suddenly it stops. You can get a heart attack. Things like stroke. Stroke is where there's a reduced blood interference with blood flow to the brain, which then affects the cardiopulmonary system. We have what we call the aortic dissection, whereby the aortic is the largest vessel in the body. And so the part of it balloons like a balloon and then bursts, and that's it. The whole blood just goes spilling and you have massive internal bleeding. Anaphylaxis or allergy. You get a bee sting, you're allergic to bee stings, you swell up, you die. Hyperkalemia. Hyperkalemia is, kalemia is potassium, so hype or low potassium causes ventricular fibrillations, you die. There's this one which was interesting, which most of us really are not screening for, which is the long QT syndrome. And I put a picture of that here. That when our heart cycle, it goes through a rhythm of relaxing and contracting to allow blood into the system. And this rhythm, God is so interesting. For us, it is just a beating. You hear the heartbeat, but that beat is nicely synchronized in this nice wave, which shows the different heart compartments that are contracting while others are relaxing to allow blood in, and then others are squeezing it out, and others are relaxing to allow blood from the lungs in. So this cycle. So sometimes when our ventricles, the main vessels of the heart, are supposed to be contracting and relaxing so that they can absorb all the blood, either from the body or the one from the lungs, delays in that system can cause you to have ventricular fibrillation and you die. So this, what we call ventricular fibrillation, where your heart is just bouncing up and down, is very dangerous. Drug overdoses, with cocaine overdose and you pass on in 1 hour. Electrocution, you're walking, there's a live wire, there's some water, you get electrocuted. Drowning, you don't know how to swim, but you want to go to the swimming pool, you drown. Trauma, road traffic accidents, and all that. And then for the babies, sometimes we call it cot death, when the babies die in their beds, unknown. So I've added to this list common instances of drugs, either overdose or the ones causing this long QT. Common drugs that we use, and we are not really aware about their side effects. If you look at, include common antibiotics, how many people take ciprofloxacin, the quinolones? How many take fluconazole, antifungals, without thinking of some of these side effects? So we need to really read up some of the side effects of drugs that we have, because some of them can cause us sudden death within 1 hour. Yeah. Drug abuse. There's a lot of drug abuse now. Fentanyl, meth, all these things can cause death within 1 hour. So we shouldn't just think it is heart attack that is responsible for death within 1 hour, but any of these can cause you to die within an hour. Then what happens? What are those causes that at least allow you another 23 hours of, in case you're rescued, you can get away with it? We can see that most of the causes of that cause death within 1 hour will also be reflected here. But here we add on other causes. And this is where sometimes we add on, if you've been otherwise, you're healthy, but maybe you have something underlying, then that can spark off some emergency, and then you end up dying in hour. And usually this, if it's witnessed or if it happens like in acute care settings. So we will still have the different varieties of causes. And the first one, cardiovascular causes, things that are related to your heart. So this heart is very precious, both physically or emotionally. The heart is very precious. So anything that will cause your heart to beat irregularly, remember, ventricular fibrillations, long QT, anything that is going to cause you to get a blockage of your heart vessels so that they will not, the heart muscle will die, and then you get a massive heart attack. If you have grown up and you have a sick heart from, if you've had like pregnancy-induced cardiomyopathies, meaning that anything that enlarges the heart, so you take alcohol, it can destroy your heart. HIV can destroy your heart. Pregnancies can destroy your heart. Things that affect the doors, the valves of your heart. So you are young and you get what we call rheumatic fever, then you get rheumatic heart disease, and your valves get scarred and they cannot close nicely. So each time the heart is pumping, blood is flowing back. So you get heart failure from all these things. So you're at risk of, if anything goes wrong within 24 hours without resuscitation, you're at risk of sudden death. Then we go to the middle section, the respiratory causes. And of course, we've talked about the massive heart lung clots, which we call pulmonary embolism. Then there's this one, which we call status asthmaticus, people who have asthma, and you get a very severe attack. If it is not handled immediately, you can go into what we call the emergency and then unfortunately die. It's one of the causes of death within 24 hours. What we call acute respiratory distress syndrome, I'll talk about this later, which we saw a lot during COVID, can cause death within 24 hours. If you get a foreign body, you're eating, you choke on a piece of meat. Unfortunately, most of the things we choke on are heavy things like protein, meat, chicken. It's hard sometimes to choke on beans, vinyewa. So you choke on that. If you're not rescued quickly, you can die. Then we have the neurological causes, stroke. All of you have heard of stroke. Stroke, somebody is walking, then they say, yakutuse, nagwa. So that instant, you can die. It's one of the causes, you can die within an hour, or if acute help is not, treatment is not given. Hemorrhage, you have hemorrhage, bleeding in your brain from stroke, from accident, from anything that causes you to bleed from in your brain, that can cause you death. Then also another emergency, especially among patients who have epilepsy. You can be having your epilepsy, and then suddenly you get your convulsions, and then they are non-stopping. So what we call status epilepticus. And that is another common cause of sudden death within 24 hours. The list continues, bear with me, because these ones are more. So we also have, as we talked about, drug overdose, but small things like carbon monoxide poisoning. So this is common, especially in children who lock themselves in cars, and they are
This is your last episode.
Ignition, and if they manage to start the engine and then the fumes from the gas comes through, they're prone to die from carbon monoxide poisoning. The other one is the metabolic causes.
The story continuous. However, each season has a different.
Everybody has their mics muted.
Every episode is like there's a different issue. I don't understand.
Susan Claire Kavuma. Susan Claire Kavuma, please mute. Thank you.
Thank you. So the other common causes in our community are related to metabolic causes, and these are mainly among people who have chronic kidney disease or diabetes. So chronic kidney disease, they get kidney failure, and then they have their electrolytes, either sodium or potassium, and then those, especially potassium, cause death within 24 hours. We know the emergency among diabetics, ketoacidosis, where they get into this state of coma, and if they are not treated on time, they can die within 24 hours. We've talked about, of course, accidents, gunshot wounds, you can die within 24 hours. We've talked about allergy anaphylaxis, but then now we also have the infectious causes, which are not really in the 1 hour category, but they creep in within the 24-hour category. You can get your infection, and one of them was COVID. All those viral infections, you get a viral infection, you get you get a bacterial infection, you get underlying sepsis, which is just sepsis means that it is the chemicals produced by the bug or pathogen or microorganism. One, they stimulate an immune response, and both those chemicals from the bug and the chemicals of the human of the host combine, and then they drive this whole thing of sepsis. And then most times we get septic shock and then die if not treated. So there are very many. I'll return to this other cartoon to show you that this is just a summary of them. Here we have a heart attack. Here we have the aneurysm. Here we have stroke. Here we have aneurysm in the brain that have burst and ruptured. Here we have drowning. Here we have anaphylaxis or allergy. Here we have gunshot wound. Here we have obstetric causes, PPH, bleeding after birth. Here we have our blood clot. Here we have our choking. Here we have fractures of the femur, which sometimes give you a fat embolism. And then here we have poisons. So this is just a summary of what can cause us to die within 1 hour or 24 hours. So what are those, I've called them prodromes, what are those beginning symptoms and signs that are warning signs to us that this might be happening? One is a common one, chest discomfort or pain. Chest pain, you feel like your chest is tight, you can't breathe. That is a warning sign. Do not ignore it. You'd rather over seek care than under seek care. If you feel any chest tightness, unusual chest tightness, please question it. And if it progresses, seek care immediately. Shortness of breath or breathlessness or a wheeze out of the blue. You suddenly feel that you can't breathe, you're short of breath, you're sitting on your desk, or you're from the bathroom or something. Don't ignore it. Sudden weakness or unexplained fatigue. You suddenly feel like all the energy has been drained out of you at that. Do not ignore that. Fast beating heart, out of the usual. Sometimes when you get scared, your heart beats a bit and you're like, okay. But now this one, it is beating and it is beating very fast and you're not understanding why, because you've been okay. And what is causing all that? There's no tear gas, there's nothing. So why is the heart beating that bad? Sweating out of the blue is one of the most sensitive, specific signs you can have that something is really not right. You suddenly sweat out of the blue and you feel that the sweating is associated with that weakness, with or without the chest pain. Do not ignore it. Nausea, most people who get heart attacks say they first get that nausea and they feel like vomiting. And then all these other things happen. Do not ignore, if you're not pregnant, do not ignore that nausea. Dizziness, that you feel very faint, sometimes, do not ignore that. I put here the hand sign. Your hands are very good. They'll show you where the pain is. You'll find that whoever has chest pain, that excruciating chest pain, they'll touch the chest. If it's the headache, they'll touch the head. If it is, they'll touch where that pain is. So when you see somebody touching somewhere, or they fall with their hand in a certain place, if you're witnessing it, you can get an idea of what's happening. Then, of course, the actual ones is sudden collapse, fainting, loss of consciousness, coma. And then, unfortunately, you feel for a pulse, you don't get a pulse. You look to see if they are breathing, you don't see them breathing. And then you see the stare of death. So we hope that before we can get to the actual, some remedy has done in the initial one, symptoms and signs. So the question is, who is at risk? Who is at risk? And you will see from all of us who are on here, online, I'm hoping that we'll find, at least you might find a risk factor. So, of course, underlying medical conditions. If you are hypertensive, you have high blood pressure, you join the risk. If you have diabetes, whether it is type 1, the one which is genetic from young, when you're from your childhood, or type 2, which is related to lifestyle, you join the list. If you have what we call coronary artery disease, you frequently get those chest pains, we call it angina, on and off, you know, you're on the list. If you are a patient with heart failure, unfortunately, you join the list. If you have a pulse that is not regular, even as you are now, we call it atrial fibrillation, you are at risk. If you have high cholesterol, high bad lipids, you're at risk. If you have a previous history of stroke, or even what we call a transient ischemic attack, you didn't get the full stroke, but you got some of the stroke signs and symptoms. If you have chronic kidney disease, sorry, the host had muted me. If you have HIV infection, sorry, you're at risk. There are so many other medical conditions I didn't put here. You're at risk. Are you seeing that risk profile? Then we go to biological factors. Now, if you're obese, I don't know if this is projecting well, but if you're yellow, brown, and red, just know you have joined the risk group. Ideally, we should be the green man or green woman. But if you're yellow, brown, and red, you're at risk. If you have abnormal distribution of fat, like you see the apple fat, which is visceral fat, unfortunately, you're at risk. You see the pear is not bad because the fat is below the waist. This is not bad. And all women, we want to be 8 shape. What's that shape 8? Yes, the pear 8, not the apple one. No man, no woman needs to be in this category. If you're advanced age, so you know, once you hit 40, you are approaching the risk. Once you go above 60, you're definitely in the risk age group. If you're a male gender, sorry men, but if you're a male gender, you have additional risk. We're still talking about the risk. Who's still at risk? If you're a smoker, luckily, I know most of us on this forum, it may not be smokers. If we are physically inactive or we do not exercise, we have joined the risk. So you see, and don't say that, for me, my job keeps me busy. I'm always walking up and down in town. I move from Chiembe to where, no, that is not physical exercise because you are working. So your body is not relaxed. This is outside your normal working hours. You go out and do that activity, that exercise, that is true exercise. If you're eating unhealthy, you're adding to your risk. So you can know from number 1 to number 3, you can list your risk score. If you have family history of hypertension, of diabetes, family history, somebody in the family, especially a first degree relative who has gotten any of those stroke, heart attack, you're at risk. Pulmonary embolism, especially, you're at risk. If you abuse drugs or alcohol, you're at risk. There's a new thing called sleep. It's not new, but something that we never neglected is the word I wanted. Sleep apnea. Sleep apnea occurs because of this apple. We don't want this apple. Apple really affects our sleep and can cause sleep apnea. So that makes us at risk. So you can see that the risk factors to sudden death are so many, and they are part of us, and they are the normal things that occur. So, talking deeply more about one of them called pulmonary embolism, because this is the one which puzzles most people, because most of the people who suffer pulmonary embolism are otherwise truly healthy. Unlike heart attack, you'll have had your initial things, underlying medical conditions, so making you at risk. But for this one, most of the people who have died from pulmonary embolisms, most of them have been otherwise very healthy. And so what does it mean? So this is basically when a blood clot, which blood clots in the deep veins of the legs or the pelvis. So the clot can sit there and cause you no problems, or sometimes it can move. And when it moves straight to the lungs. But remember, it has to also move through the blood, because blood comes from the, so it comes straight to the lungs because that's where this deoxygenated blood goes. So the lung is the first culprit. So once it gets there and it blocks the 1 or 2 arteries, that means it is big to block. Then we get pulmonary embolism. Sometimes there are small blood clots, so people usually survive. But if it is massive, it is difficult to survive. It is common for asymptomatic pulmonary emboli to occur. It is common. And unfortunately, because people do not get symptoms, so people do not know that they are at risk of this. So they do not investigate, they do not screen, they do not seek care. But of course, it's presented with that sudden breathlessness, very bad chest pain, tightness, which worsens when you breathe or when you cough or when you move, the pain gets sharper and worse. So you'll see them saying they are breathless. They say the pain is too much. They cannot do much. They double over. And if it is so bad, they start coughing out blood. Then you know things have really gone bad. And people who are at risk of, especially pulmonary embolism, who it is not from familial or genetics, are those who have had a recent surgery, especially pelvis. Orthopedic surgery. So remember, orthopedics, those are people who have had fractures, people who are repairing vertebra. So common surgeries in orthopedics. So the high risk factor there. But any other surgery or cesarean section. We also have many people who undergo cesarean sections. And some of these things, people are not aware of the risk from that. The others who is not surprising are those who have been sick for a very long time and have been bedridden. So you're bedridden, so the blood back to the heart is slow, and so even from the disease, so it gets thicker, it clots. The other people, because you've been sitting on this bus, now you're coming from Kampala to Dar es Salaam. These things of feeling lazy to get out of the bus, to stretch. So you sit, maybe you get out on the borders, but other than that, you're seated until Dar es Salaam. Or you're on the flight from Entebbe all the way to San Francisco. You don't even get up. So that long time when you're seated is another risk factor for getting what we call deep venous thrombosis, the clots in the veins, which then can lead to the pulmonary emboli. If you have a history of getting this deep venous thrombosis, when you're pregnant, your feet always swell, not because of preeclampsia, but because of deep venous thrombosis, DVT, just know that you should be aware that you're at risk. So you should always have precaution. The state of pregnancy alone makes the blood thicker, increases coagulability of the blood, and the whole birthing process, that is a risk factor, and we have many people who get pregnant. The other, which we saw in recent times, is COVID-19, and talk more about that. So this whole history of COVID-19, before COVID came, we never knew there would be, in our generation, a disease that shuts down the whole world, that confuses the world, that comes up with so many presentation styles that we even never know. So COVID-19 came, and it brought a lot of mortality that people would die within 2 days of getting infected. Within 1 day, you are like, oh, but that person was okay. They are dead already, especially the virulent strain of Delta. So COVID-19 recognized us. So there's I got this from Coy et al., who published from Korea some of the things that were attributed to sudden death from COVID, and who are the people who are at risk of that. So the people they saw that who were dying within this short time, the sudden deaths from COVID, were male, older age, otherwise healthy, people who had not been vaccinated with the COVID vaccine, and also people who had comorbid conditions, especially diabetes. So pulmonary embolism in COVID, the prevalence of this reported in literature is varying, and it varies between 17% to 30%. So it is that prevalent. So it is something we know that COVID is still with us. It has not gone away. So we are still having the same risks. So what causes this pulmonary embolism in COVID? The first is that the blood becomes thicker. It becomes hypercoagulable. Why? Because of the cytokine storm. What happens with the cytokine storm is that when we get COVID, the virus, it is a virus, so it goes into the cell. It goes into the cells which eat the macrophages. So those macrophages stimulate the release of pro-inflammatory cytokines, especially interleukin-6, interleukin-8, and tumor necrosis factor, TNFA alpha. These then go and cause rapid tissue damage. But at the same time, they are releasing other chemicals which then cause the blood vessels to cause the cells to stick to them. So then there's a lot of because of also the cytokines are proteins. And they also induce what we call the acute phase reactants. So C-reactive protein, those inflammatory markers, D-dimers, C-inflammatory proteins, and all that. So this all make the blood very thick. So imagine soup. If you put many virungo, the soup becomes thicker. If you only put tomatoes and onions, it is light. But you add Royco, you add what, it gets thicker. So that is what happens. So this is what the COVID virus was causing, or does still cause, especially the first strains of Beta and Delta, especially Delta. Omicron, not so much, but it did. So currently, I'm not sure we haven't known what is the current resident or residual strain currently happening now, but it is not causing as bad symptoms as the ones. So, but this also can happen. It's not only to COVID-19, but also all the other influenza, avian flu, the previous SARS. So all these have the same effect like COVID-19. So still, of course, we know that there's a presentation of shortness of breath, chest pain, and coughing of blood, which would occur from just the presentation of the clot in the blood, in the lung. But so who are these people who are prone to getting pulmonary embolism or blood clots in the lung due to COVID? There were those who had very severe disease, so they needed ICU. Those who had been home, even though home or in hospital for a long time. We've said those who are older. Now here's a new one, which was not reported in Korea, but has been reported in all other literature. Those who are obese. Obesity was directly had a direct correlation with pulmonary embolism. And then those who had all these other underlying diseases. So your hypertension, your diabetes, your sickle cell disease, your HIV. So all that increase your chances. And I just put this to show that even what COVID also does, it causes what we call the acute respiratory distress syndrome. And this is a result of, remember that cytokine storm? So it messes your lung. You do not have any lung. If you look here, there's no lung anywhere. And so your the lungs appear dead, very pale, sometimes black compared to what should be normal. So already this acute respiratory distress, because it also presents with the same symptoms and signs of pulmonary embolism, most times people were missing pulmonary embolism because they were thinking it is acute respiratory distress syndrome only, which also had a high mortality rate in COVID. So after thinking all through this, with knowing that prevention is better than cure, what can we do to prevent these sudden deaths? From all the other list of risk factors to even things that are associated with COVID. One, keep your heart healthy. The heart is central to everything. Keep your heart healthy. How? Do regular exercise. I know we have had all this, it's like your church and you're hearing the same sermon, but we need to really practice this, guys. So exercise, eat well, go for that regular checkup. I don't know how many of us do our checkups, how many try to screen for hypertension, any heart disease, QT syndrome, and your heart actually has not been beating well, and it's by God's grace you're still alive, and you don't know when anything can change. How many know whether we are diabetics or not, especially if we have family history? We can avoid all bad habits like smoking, alcohol. And if you're ill, make sure you have good control of that illness. Make sure you control that blood pressure, be regular with your medication, diabetes, control that cholesterol, and genetic tests in the West. I'm hoping that soon now people can go and look for genetic associations to see whether you have some of these predisposing factors. And if you know that you have had a previous episode of near sudden death, luckily God helped and you did not die, but you got the near death. Now there are advances whereby you don't have to wait for somebody to call 911 and the ambulance to come and people to perform cardiopulmonary resuscitation on you. They are implantable cardio defibrillators, which they can put under your clavicle. And if anything happens, you can resuscitate yourself. So if you're alone, you in the house, you're sorted. Or you can even buy an automatic one for home use. So medicine has really evolved. I don't know if maybe some people in Uganda have these, but I know these are mostly in the West. And sadly, the complications of sudden death result in two things: either brain death, and you become a vegetable, as we call it, vegetative. So you can breathe, your heart can beat, but your brain is gone. And people have lived for years because no one can switch off that mechanical ventilator. So there are two complications: brain dead, or brain damage, or brain dead, or actual death, sadly. So we shouldn't take this lightly. We should really be very health aware. Yes, and thank you. And I'm happy to take on any questions. Over to you, Dr. Emily.
Thank you so much, Prof. A round of applause, ladies and gentlemen, to Professor Irene Andia Biraro. You know how to use those reactions. Thank you. You know how to use those reactions on the screens? I can't see, let me, like that, like mine. Okay. We truly appreciate you. Thank you so much. This has been very, very informative. I think of all things that we've learned, we've actually realized that almost all of us are at risk, you know, especially with the coming of COVID. But I'll open up the question and answer session to the members. So I know that some of you have been sharing your questions in the chats. But if you have a burning question, kindly let's have like 3 questions and we'll take another set of 3 like that. So raise up your hand and then we will take it on from there. Okay, so as questions are coming in, let me go first. So Dr. Irene, so there is this fear that has been going on, especially after COVID, and about the vaccines. So in your presentation, we have seen that the COVID itself was a predisposing factor because of the of its impact on the cardiovascular system. How about the COVID vaccines? How about, the aftermath? What do you have to say about COVID vaccine and pulmonary embolism? My other question is about for frequent travelers. So we have seen that embolism is, it can happen after a long distance and you're immobile. So if I'm a traveler and I am above 40, should I just go like that, or should there be any precautions I should take? I think let me stop there for now. Irene, you can go ahead with your question.
Thank you, Dr. Emily, and thank you, Professor Irene. I think mine is just to read out some of the questions that were in the chat, in case they were not very well captured at first. How does fluconazole, someone asked, I think that was Joey, how does fluconazole cause sudden death, and what are the alternatives? Then another burning question that caused some good discussion in the chat was, okay, those who collapse, do they die first, then they fall, or they fall, then they die first, then they die, sorry. Then the third question in the chat was, how do I know if I have clots? Over to Dr. Emily.
Okay.
So thank you very much for the questions. I was looking at my pen, but I'll try to remember. So yes, Emily, you asked about the COVID vaccine and deaths associated with the COVID vaccine, and also what can long flight or long travelers on long distance travelers, what can they do? So yes, the vaccine. I say it quietly that I think the COVID vaccine for me, especially AstraZeneca, was a bit horrid. It had a lot of side effects, but unfortunately, despite all of us not liking it, we have not managed to carry out evidence-based research to understand which were these side effects really. One, because of how it was rolled out, and two, at that point, that was not our biggest area of concern. We started thinking about it after everything else had settled. And also, believe it or not, many people do not take the vaccines. So we were unable to look and really pinpoint different side effects, especially things like pulmonary clotting. But there's inferences. Although there's one study from the US in Oregon, Portland, at about 2 years, followed up 2 people who had received the vaccine and followed them up for 2 years. And they were particularly looking for that. And they said out of the I think there are about 1,000 participants they followed. I think it was 1 or 2, and they could not pinpoint it to the actual vaccine. So so we cannot say really whether the several deaths we are seeing now are because of the vaccine or the actual disease, or maybe just your risk factor that you've been having and now it's causing you problems. Yeah. So and now because there's a lot of vaccine hesitance, when you tell people to even go for the booster, there was very low coverage. So it's even harder now to study that question, because now if we were still getting booster, we'll be able to do the research to look for that causal relationship. Then the question on what should the long distance travelers do? One, keep hydrated. So don't fear that you need to use the loo. You just have to stop that bus and tell them you need to use a loo. And usually the bushes sometimes are very good side loos. So to be hydrated, get up, even though you're not going to do anything, get up from your seat, go into the corridor, walk around. Planes are ideal because you can do your walk as much as possible. If you are in a situation where you can't get up, there are exercises you can do. You can tiptoe in your seat, and then you tighten your leg muscles. Tiptoe and tighten. Tiptoe and tighten. That action alone helps with your blood flow. So those are some things. But also, if you are at risk, you can wear flight stockings or compression stockings to help you, but make sure you don't wear them more than 8 hours. So if you're going to Dar es Salaam, wear them 8 hours, get a break for 4 hours, wear them again for 8 hours. If you wear them from Kampala to Dar es Salaam nonstop, now you get the side effect of, like, it is a tourniquet, constriction. So you can cause you can cause very bad cramping. You can shut off your supply from your blood supply from your legs. So 8 hours for our break, 8 hours for our break. Yes, so so Eleanor, my pen betrayed me, but Eleanor's question, I remember the one of when those who suddenly die, do they first die and then fall? It can be two ways. The truth is, you can get a massive stroke or massive heart, myocardial infarction but no, you can't die before. You will still have to react. So you're still alive, react, then drop. So in the second of when the blood is being, that cardiopulmonary system is being disrupted, you will present with something. So you first present and then die. The only ones who die before knowing anything is either traffic accident, gunshot, those ones, which are, but the rest, you first, then you die, then you fall. So the fall can come from the symptoms, or the fall can come as towards your death. Yeah. The other question was, kindly remind me.
I think that was all, but maybe we can take on.
There was something about fluconazole.
Yes,
Fluconazole. Yes, fluconazole. Yes, thank you so much. Yes, so fluconazole. What fluconazole does, sorry, let me put back this and show you. Are you seeing my screen? Am I sharing it again?
Yes, you are.
Yeah.
Yes. So what fluconazole does is this. It increases, you see the long QT, it causes long QT syndrome. So it affects your ventricular function and you eventually get ventricular fibrillation. So all these, this is the list of fluconazole, the quinolones, the antipsychotics, things like formerly quinine, or sometimes now with severe complicated malaria, which is not responding to a test unit, we use quinine. That's what it does, the long QT. Yes.
Okay. Another set of questions, someone here is asking, I'm always having cold feet and my systolic blood pressure is always below 100 milligrams mgh. Am I safe? Then the other one is about the sudden infant death syndrome. Is it also hereditary? Is it also a hereditary risk or of sudden death? Then the next one, what does getting awareness, I'm just reading the way they wrote it. What does getting awareness pulsations in the neck and head while sleeping indicates? I think they are getting pulsations. They are aware of their pulsations in the neck and in the head while sleeping. What does that indicate? And let's take on Masereka Paul.
Let me answer those. Emily, let me answer those because I have no pen.
Okay.
So the cot death syndrome occurs usually from how you position the baby in the cot. So usually babies, this is the irony. Usually the safest way for the baby to sleep in the cot is on their back, supine. Then they're breathing very well. But babies sleep the best, surprisingly, when they're on their tummies. So you have to be very careful when you put a baby to sleep on their tummy when they're very young, before they can learn to lift their head. So anything below 3 months where they can't lift their head to turn, you have to, either you're there watching or do not risk putting them on their tummy, because what happens is because they're on their tummy, they sometimes can fidget about and then pull clothes over them, or they can turn a bit and then they block their nostril and then they die. So it is related to the posture versus any other thing. The other question was related to the low BP. A BP below 100 systolic is very worrying, especially prolonged. One, that is dehydration or hypotension. So you have to think of things that are causing dehydration or hypotension. Either you're not taking enough, either your heart is not beating well, either you are chronic sepsis, either you have severe pain, so you're getting neurogenic shock, either it's an allergy, something. If it is not dehydration, hypotension, either your adrenals are not working well, there's something wrong with your RAS system. So you cannot afford to have a sustained systolic below 100. The irony now, in case of which of the two, systolic or diastolic, which one would you prefer to be low? At this point, it's the diastolic. You need a systolic above 100 cardiac output to maintain a good flow to the rest of your organs. Otherwise, that chronicity will lead to one of your main organs dying. So think about that and seek help as soon as you can, and so that you can get to the bottom of it. The cold feet, what was the question about? The end of the pulsation. Yeah, so the pulsations in the neck and the head. So the neck pulsations and the head, so different things can cause the different pulsations. So a pulsatile neck can be, the one which is really visible is either carotid or external jugular. So external jugular is a vein, the carotid is an artery. So if you want to worry about what's happening with your upper circulation above the superior vena cava. And if it is from heart failure, that one is in internal jugular, and it's really hard to doing a clinical exam. So if it is visible and you're feeling it, pulsatile, that is most likely your carotid artery, we worry something is happening with your arteries above the superior vena cava, especially the subclavian arteries. Sometimes they can cause problems. But the pulsation at the neck is now a different artery. And sometimes people who have like giant cell arteritis, arteries, inflammation of the arteries can have that, and then they also get a very bad headache. So I'm thinking it is linked. So you might be having an arteritis that needs to be investigated. Yes. Are those the ones?
Yes, those are the ones. So let's have the next 3 questions. Masereka Paul, please unmute and ask your question.
Thank you, Professor. My name is Masereka Paul, and thank you, presenter. I have one question and a concern. We have always heard of sudden deaths among the youth, and people have attributed it to the youth taking drugs for sexual enhancement. Professor, I wanted to ask, should we take message to the youth that the use of self-prescribed medicine for sexual enhancement is also one of the leading causes of sudden death? That is one. Then number 2, I wanted us to have a culture of encouraging people to take on postmortems in cases of sudden deaths, because normally when sudden deaths happen, culturally, people tend to attribute them to a lot of things. At the end of the day, you find a lot of wrangles in communities. And yet, including health workers, people have a negative attitude towards postmortems, and yet they increase the successes of collecting data and perhaps increase on clinical practice. So my second concern is a request that we should always encourage people to take on postmortem so that we ascertain the cause of deaths, and it can help us collect data, remove fictitious conclusions, and also improve on the clinical management of cases once they happen. Thank you. Over to you, moderator.
Thank you so much, Paul. Those are very interesting questions. Irene, you want to add on one more?
No, I just want to thank you, Paul, and just to thank you for bringing the sudden death from sexual enhancers sildenafil, which is the most common culprit. It's interesting that most of these deaths actually are among the men who are more not young, the older men. Yes. Yeah, especially those who have chronic illnesses often misuse the drug, although it is such a good drug for pulmonary hypertension. So sometimes people who are on treatment for pulmonary hypertension are using it rightly because the sexual enhancement was a side effect of this drug. So, but the youngsters who are abusing it, or the oldsters who are abusing it, yeah, thank you for highlighting that. And it causes ventricular fibrillation, so it causes cardiac arrest. Yes, and for the postmortems, I was happy to learn recently that Mulago is now making it mandatory for any death from it for a PM is compulsory. So that is helping us override the myths of people not wanting postmortem. So we are going to be able to have better evidence on what is causing mortality, especially from Mulago. So I'm hoping other hospitals can do the same.
Thank you so much. That was very, very informative. I know many people have taken note of that. So a few people asked, how does one know they have clots? Then the other question I want to put forward, among the causes of sudden death was this carbon monoxide. There was a time when people had concerns having sigiri, charcoal stoves in small houses. So deaths were reported. At one time, I remember there was a family that was reported death, both The mother and the 2 children died, the man survived. As a community, what would you advise? What should we take? And what are the best practices regarding carbon monoxide poisoning, which is also, we have seen, can also cause sudden death?
Thank you, Emily. So how can I know that I have clots? So as I mentioned, some of these lung clots don't have symptoms, unfortunately. And unfortunately, somebody will pass without even having known that they had it. But the biggest distributor of the clots to the lung are from the DVT. So if you have any swollen leg, which is not swollen, both legs are swollen. Sometimes they can be both swollen, by the way. You can have DVTs in clots in your legs for both legs, but more commonly it's one leg. If you have that swollen leg, you have pain at the calf behind the leg, below the knee, behind the leg, the collegiate, now they call the collegiate, that muscle. You have pain around there. If it is hot, if it is swollen, do not sit on it. Do not take it even lightly. Do not even think about it. Go to the first hospital. If you go and they tell you, oh, it's not a DVT, because now we can do ultrasound of those veins to see, especially for the legs. The ones in the pelvis is hard, but at least those ones. But for the pelvis, sometimes now we can do MRIs and they see. So do not just take it for granted. My leg, it's got swollen. It's a bit painful about what's happening. Most people say Tula. Is it Tula? Or what? And then you're there diddling. Please, that is the first sign. And if you have that sign, you thank God, because most people do not even have and know where their clots come from and present directly with the clot in the blood. Now, carbon monoxide poisoning. Yes, my advice is for any cooking where there is fumes, anything that is not gas or electricity, it is advised to be done outside. So unfortunately, our housing situation, sometimes people, if it's raining and some of these things, people are forced to cook indoors, even though you don't get the poisoning, but that fume will destroy your lungs. And most of the COPD cases we see now is from fumes, fuel fumes. So it is best, even though you have an outside kitchen, cook, but find time to get out and get fresh air. Do not sit in that kitchen with all those fumes the whole time, especially women banging KB in those fumes. You may not get the poisoning. The poisoning will only happen when there is no way out, but still you're destroying your lungs. So we advise, do not cook indoors. Simple as that. Unless it's gas or electricity.
Okay, all right. All right, thank you so much, Professor. I think we are coming to the end of our presentation. We are really, really grateful. Yes, yes, Molly Natasha raised hand. So let's take Molly Natasha, and that will be the last question because we are short of time. So Molly.
Okay, thank you so much. Yes. Thank you so much, Dr. Irene. I just wanted to appreciate you. Thank you for everything. Mine was an appreciation.
Thank you so much. That was nice of you, Molly. I think Molly has represented all of us. So Professor Irene, we are really, really grateful for sharing this, discussing this very important topic. I think we all have felt like we are at risk and we need to take the necessary precautions. And especially now with the coming of COVID, these things have come nearer to us. And to the audience, you have been such a wonderful audience. Thank you so much for your participation. Thank you for your questions and also for a good attendance. I think at the peak, we're almost 100. We have dropped to 80, but that's still a very good number. So until next time, please take care of yourselves. God loves you, and be responsible. Thank you so much, Irene, and have a good night.
Thank you. Thank you, everyone.
Thank you. Good night.
Yeah.